Hello, everyone. I'm just really excited to see some faces trickling in today. We're going to get started momentarily. Great. Well, hello to everyone that's already here and those that will be joining us. Welcome to today's Women in Medicine program. My name is Megan Phillip. I serve as Women's Innovation Officer, so it's wonderful to have you here with us. For anyone joining for the first time, Women in Medicine is a national 501(c)(3) nonprofit dedicated to educating, elevating, and advancing women in healthcare. We are the national home for women in medicine, building the continuum from medical student to senior leaders through community education, leadership development, and advocacy. A couple of quick notes before we get started. This webinar is being recorded and will be available on WIM's website under Insights within the next few days, so feel free to share it with your colleagues who can't join us live. We also welcome your questions, so please drop them in the chat throughout the program and we'll do our best to weave them into the conversation, and there should be time at the end for a little bit more robust conversation. Today's conversation couldn't be more timely. This June, we recognize Pride Month, and we're here to talk openly about what it means to practice medicine and live fully as an LGBTQ plus provider. The need is really growing as an estimate of 1 in 6 Gen Z adults identify as LGBTQ plus. Yet this population remains significantly more likely to delay or avoid care due to fear of discrimination, with serious consequences across chronic illness, mental health, and preventative care. So, transgender and gender diverse patients report especially high rates of being refused care or treated with disrespect. And for LGBTQ plus physicians themselves, the pressure to conceal identity in clinical and academic environments carries its own professional and personal toll. So, I'm really grateful that this session is meant to be an open conversation grounded in shared experience and the belief that medicine is better with every voice in the room. So, leading us off in this conversation, I'm going to turn it over to Dr. Jalen Avila, uh, who will share her remarks on supporting patients and providers through their experience. Dr. Avila currently practices emergency medicine in California and has a robust profile of teaching and advocacy engagements. So, we look forward to hearing from her today. Welcome.
Hi. I guess I'll just get started. My name is Jalen Avila. I'm an emergency medicine physician by trade, and I have a specialty training. I did a fellowship in ultrasound, and that is kind of my path. The thing I'm most passionate about within the educational space, apart from educating on queer topics. I was a national speaker. I spoke at ASAP, which is our emergency medicine's kind of biggest scientific assembly that we have every year, and had a bit of an online presence. And then I transitioned. I got to see what it was like, medicine was like as, a cis white, I'll say passing. I'm actually Venezuelan. My parents are immigrants, white passing male. And then, going from the fourth letter in LGBT. So it's been a amazing journey overall. It still is and was difficult, but absolutely necessary. And people have really shown up in mostly, like by far, mostly the kind of best ways for me, including this organization, the Women in Medicine organization.
Thank you so much. Next, I'm going to ask Dr. Jessica Bunin, who most recently was the Dean of DEI and Community and Uniform Services for the university for several years, but recently co-founded All Levels Leadership and continues her healthcare leadership and coaching through that, and is currently writing her book, From Inside Out: How Self-Aware Leaders Build Trust and Transform Healthcare, to share a little bit of a presentation and some opportunities to share her perspective as well. Dr. Bunin.
Hi, everyone. I'm going to start with a basic introduction to myself and then tell you a little bit about my story over the years. So I am currently an intensivist, but I started my career out as a psychiatrist. So I did a combined internal medicine and psychiatry residency. I was an outpatient psychiatrist for 3 years and then came back and did a critical care medicine fellowship. So I bring a little bit of psychiatry to everything I do, although I don't practice psychiatry anymore. And most of my clinical time and almost all of my time as a physician has been in uniform, which I think is a very relevant part of our discussion today. So I joined the Army in 1992. I originally tried to come out as gay in 1991, and then went to West Point and was rapidly shoved slash ran back into the closet when I was very well aware of the situation there, which was that if any woman was gay, they were either, or man, they were either removed from the institution or made pretty miserable while they were there with many threats. And so it was very clear that during my time there, I would not be honoring that part of myself. Graduated from West Point in 1996 and went to med school at Tulane. Graduated in 2000. And during my time at West Point, Don't Ask, Don't Tell began. So before Don't Ask, Don't Tell, it was really if you were gay, you were completely removed from the military, often through a trial, which was a very unpleasant experience. In 1994, it got to the point where if you didn't talk and you didn't share the fact that you had a significant other, and if no one asked you, then it was okay, which made lives still very difficult to be in the military. And so for all of that time, I just didn't bring significant others to any of the work functions, didn't talk about significant others when I was at work. Like we couldn't just say anything about like what we did with our weekends, that sort of a thing. So Don't Ask, Don't Tell was a really challenging time. And then in 2011, Don't Ask, Don't Tell was repealed, which was sort of magical. Overnight, we could talk about ourselves, we could use appropriate pronouns, we could introduce spouses and bring them to parties. And it really did change instantaneously overnight, which was a fascinating thing to watch. And so soon after that, I got married. Like, my wife was very well accepted into the military community, which was a wonderful part of that as my wife. And so it was huge to see that change. And I want to point that out so that if anyone is in the military now and is struggling with what that means, I will just say that there is sort of a constant up and down of acceptance in the military, and what it is now will not be what it is for your entire career. And I can always be a resource to talk to about that if that's helpful. In 2023, I retired as a colonel in the Army. Next slide. Oh, one back, please. So I want to make the point that when you're a physician or when you're in the military and you're coming out, you don't have a day when you come out. You come out multiple times every single day and do a lot of mental math about what that means to come out all the time. And I will say before coming out, I was really safe in my work environment. There was no concern about how that would affect my career. And I had some additional belonging in my work environment that I was fearful would go away if I did come out. And I was fearful that I would lose my family if I came out. But I was able to go forward with a military career without much worrying about it. After coming out, all of the losses that I feared came to reality, which was a two-sided coin for me. Partially, it was heartbreaking, but also partially it was it made me feel a little more authentic. It made me feel like my thoughts were appreciated and were true, and I wasn't sort of making a big deal out of things over the years. But was disowned by my parents and was ostracized by several folks at work. Particularly, we had some religious folks who were in the critical care community who had a very difficult time working with me and communicating with me after they found out, and I didn't know what that was going to mean. But it didn't matter to me because what I gained was being able to openly have the love of my life, authentically represent myself in situations, and be able to be proud of my spouse. I suffered depression, which is not uncommon in the LGBTQ population. And almost the day that I came out, that vanished. It was so difficult to sort of hide who I was and worry about that on a daily basis. And it did allow for a lot more deep, meaningful conversations. Next slide, please. And so I want to make the point that in the literature, we see over and over again that it's about 4 to 6% of physicians who report that they are LGBTQ. But I think historically that's very small number compared to who are actually out there. Because a lot of folks still don't feel safe reporting who they are, or what their gender is, or anything along those lines, what their pronouns are, what their sexual orientation is. And I would just say you may feel very alone where you are, and I assure you, you are not. There's a huge population of folks who would love to support you, and you deserve that. You deserve to feel the safety and the belonging and the respect and all of the things that I felt when I came out, which is this is just so worth it. And I can have my mental health back, and I can have my family and all of these things. So community does exist, and we are here. There's a society called the Trevor Project, and they sell stickers that say it gets better. And I really want to say that it does get better, and I feel like every day it gets better. So it's not easy, but it is definitely doable. Thanks, Megan.
Amazing. Thank you so much. So I'm gonna now kind of invite both of you into the conversation, and both of you have such different but unique perspectives on this, and I just welcome you each to kind of, I know that Dr. Bunin, you just shared a little bit about the journey of coming out, and Dr. Avila, you also shared a bit of that, but I would welcome you both to share what the differences are of when, I'm not to age either of you, but it was a distant in the past, right? And where we are today, and how you are supporting or thinking about colleagues and providers or family on the clinical side as they think about it as part of their career, and what that looks like to come forward, as well as what you're doing with your patient population. So I would welcome either of you to take on either of those to start.
Jalen, I'll let you run with the patient provider side.
Right on. Um, so there's kind of phases to transition. I started transitioning in my kind of mid to late 30s. I'm 41 now. I'm very happy to age myself because I've made it, and I'm happy. And I'll tell you, just being vulnerable and disclosing everything, I don't think I would have been alive more than like 2 or 3 years tops if I hadn't been able to transition, because hiding that part of me was was so kind of smothering and so oppressive that it kind of painted everything that I did, including my family, my friends, my work colleagues, my patients. And after coming out, it was better as a whole. I mean, there's things that I kind of like realized after I, completed my transition, and I say that in air quotes because I never feel like I'm gonna be exactly the person I want to be because I'm always striving, 1% better every day. The more difficult time, I would say, is the in-between phase. I had a lot of what I call kind of tongue-in-cheek testosterone poisoning, and I had a very masculine features. I had a masculine skull, a body shape, and a voice that right now, this voice that you're hearing, is not a result of estrogen. It's not a result of surgeries. It's the result of me purposefully putting my voice in this register every time that I talk, which now I'm on it's a bit of autopilot, but even just like that aspect of it is kind of tough. The in between phase lasted about a year and a half, where I presented as a woman, but still on, aside from the clothing and the makeup, still very much looked like a man. And that's kind of tough to live and continue to work and continue to be in society in that middle phase. But getting through that with therapy, because I'd like to think that I'm a very studious individual and I'm very action oriented. And I put in the work, I continue to put in the work, but there's also a transition that kind of had to happen with work colleagues and with patients as well, and learning to be patient with them as we kind of went through this together was important. And once I realized that, for instance, my mother was also transitioning with me as having, instead of two boys, having a boy and a girl. And that was a little difficult for her. She's a great lady. I love her. She is a little on the old school side. I grew up in a military household. My dad was in the Navy, conservative Christian, and immigrant kid. I was first generation here, and so those rigid kind of gender roles were almost like a requirement for everything else. It shouldn't be, but it almost was. And going through that was difficult. Now, with patients specifically, what's interesting is that even in that in-between phase, that if I showed kindness and respect to my patients and listened to them, which I'd like to think I always did, they tended to not be as hung up with the transition, with at the time, the kind of non-binary, gender fluid kind of presentation that I had. As long as I was kind and patient with them, they often, most of the time, were able to give me that back. And now it's great. But I do notice that there are things that, those what we call microaggressions that I'd always heard cis women say, and I always tried to be an ally. I always tried to call them out before my transition, but I didn't realize how pervasive those things were from a colleague perspective, so professionally, as well as from kind of patient focused aspects of it.
Yeah, so interesting to hear, Jalen. Thank you. I did never had to deal with the code switching part of it as much as you did, having to change your voice on the regular. I
Hmm.
never had any of sort of that stress that goes along with that. And I'm really grateful for that, because I can't imagine how exhausting that is. Because I personally found it very exhausting to try to practice as a physician, be thinking in critical care about all the things that I need to do in every given minute, and then have a family member say something like, your husband is so lucky to have you, and trying to weigh each time, do I tell them, do I not tell them, it's my wife, not
Hmm.
my husband, and every single time thinking, is this person going to think less of me, or are they going to want me to not care for them or their family member, every single time. And I felt like that was a lot of additional cognitive load that doesn't
Hmm.
happen for most folks. Like, it's hard enough to be doing patient care and teaching and research and leadership tasks and all of these things without having this secondary voice in your head. And I can't imagine having a secondary voice in my head and trying also to speak in another voice. So thank you for sharing all that. But overall, I think it's really important to remember that for LGBTQ physicians, most of us are experiencing this to some degree, and leads to a much higher rate of burnout in LGBTQ providers than it does in others. And a big difference, like half of LGBTQ folks and a third of their peers at any given time, which is pretty overwhelming to think about. But again, I just feel like that weight is so worth carrying if I can show it to one person. If one person can hear me talk. And there have been a lot of just joyful moments for me. I go out of my way. Ever since I became a lieutenant colonel in the Army and I had an opportunity to speak in public, I always tried to bring my wife into my conversation and just normalize that for others who didn't have that or were afraid. And pretty regularly with students, I would get a note that was left on my desk that said, I never thought in a military population I would hear someone mention that they were gay in a presentation, and it made my day, and I would really love to talk with you. I've had folks who were trans come and say, I don't know who to talk to or where to go, but I heard you mention your wife, so I know that you're safe. And so I think every single time that I made the conscious decision to bring it up, I was grateful that I made that conscious decision to bring it up.
Yeah, absolutely. I second all of that. And I think one of the more important things now, especially for us queer people and especially for trans people, is the visibility aspect of it. And on top of all that, will the patient's family not want me to be their physician? For me, especially when I'm out in public, and I like to hang out I live in San Diego, and there's a kind of a gayborhood, for lack of a better word for it. And when I'm there, let my guard down a little bit. But when I'm we have a lot of military presence here in San Diego. And when I go out to Gaslamp, for instance, which is a popular kind of destination spot for people to go out, I also have to be extra careful because it's actually like a safety thing for me because we get targeted, unfortunately. And when you're out in public, it's sometimes you're in a crowded bar and it's hard to kind of escape. And so there is also that aspect of just, is this person going to assault me?
We've kind of covered this a little bit, but Jess, I'd love to dig a little deeper into like this. The psychological weight of this is really critical. There's a lot of code switching, hypervigilance to um, not only just what your identity is from a career perspective, but even just as Jalen mentioned, it's a safety precaution. So for clinicians, how do we look at that? I mean, it sounds like by being brave on each of your parts to show that in the space. You said you've had students feel more empowered to be supported. So what are the offerings that you have outside of, be brave? That's like one thing to just say it, but what does it look like in practice? And then how are you also protecting yourself? And like, what are some of the, mental health supports or things, whether it's traditional therapy or other resources, as well as, this can burn you out just in this alone, and medicine can burn you out just in the practice of what you're doing. So I know I'm adding like multiple layers to this question, but I'm looking at this continuum of psychological safety and would love to start with you, Jess.
Yeah, I think it's so important to talk about. I will double what Jalen says about safety. Safety issues are real for all LGBTQ folks, certainly more for trans than for others, but all around. And so my wife and I, if we go to hotels together in many states, we don't check in together. One of us checks in and one of us does not.
Mm,
We very rarely will hold hands in public in certain places, and we're very conscious of that.
mm,
For the first time in my life, I actually watch for guidelines of what states are safe to enter and what ones are not, based on your race or based on your sexuality. So I pay a lot more attention than I would like to have to things along those lines. But I cannot emphasize enough the value of community. And there's people out there that want to be there, that want to support. There's groups out there that, for example, for trans folks in the military, Sparta is the main group that does a lot of the advocacy as well as creating community. And I think having even one person who can be that community for you that you can go to when you need to can make all the difference. So absolutely, if you're in a place where you have the privilege to be able to talk about who you are and show that to everyone, then that you never know whose life you're going to change by doing that. One of my friends, I was stationed in Hawaii for 5 years. I was creating a mentoring program, and I put a slide up that had a picture of my wife on it as far as who might want to come to me for mentoring. And that weekend, someone came up to me and said, I proposed to my boyfriend, a man, because you were so comfortable showing a slide of you and your wife that it empowered me to propose. And things like that happen all the time. So if you have the privilege to do it, doing it, I think is huge. And if not, I actually think treading lightly is really important. And there are going to be people where it's very obvious who they are. Like I always am looking for people's water bottles. Like I have
Hmm.
some sort of LGBTQ pin or sticker or jewelry on me at all times. And so look for that and then take advantage of those people being around. And for folks who are not, who are just allies, like having that available for folks to see, it honestly lowers my heart rate when I see someone else who I know right off the bat is accepting.
Jalen, I feel like in the fast-paced environment of the ED, you have to kind of pick up on those signals and probably show and honor that. So, I mean, sometimes a patient very quickly is showing vulnerability, and how do you navigate that or support that? And how do you teach your colleagues to support that in such a fast-paced environment?
The I think the overall thing that I try to tell people when they ask me that, and this is other providers, what can I do to be supportive? How can I make somebody feel comfortable? The main thing is what Jess mentioned is I always have something on me that shows that I'm queer. At work, I have this watch band. I try to have a necklace, something, or it's something as easy as a sticker, just like a little pride sticker. That you can get on Etsy, by the way. They're kind of cool. They stick out a little bit, and you can just stick them on your badge. They're easy to take off too. To have something on there that even if you yourself are not queer, that queer people would know that it's essentially not a non-issue. There's intersectionality, and me being a trans woman is a very important identity to me. But in reality, it's like number five as far as like identities that are most important to me. My most important identity is that of a woman, then a wife, then a mother, and then medicine, because I love working. I love my job. I love medicine. I love learning. And then as number five is me as a trans person. And as far as the patients themselves, letting them kind of lead the conversation and mirroring the words that they use to describe themselves and describe others around them, describe their spouse, is also something that is helpful. And as you mentioned, in the emergency department, I would love to spend hours talking to my patients truly and giving them exactly what they need. But in reality, my face-to-face time with patients might be at most 5 minutes. And I have to kind of figure out in those 5 minutes, firstly, what information can I share? Because sharing parts of yourself with patients often helps them open up more to you. And to be an effective physician, there has to be trust. Your patient has to actually trust you, listen to you. And the way that I've learned it helps is to be vulnerable on my own. And one of the things that I've noticed, and this is with gay, with lesbian patients, and with trans people as well, is this kind of change in their kind of stance, their countenance when I mention my wife. And to see that relief that I'm not judging them and I'm here to be their medical provider. And I really don't judge people as long as they're not hurting anybody else. I don't judge anybody for what they do. Just like I don't understand why people watch sports all the time. It seems repetitive, and it seems like a lot of work, and it's a lot of time, and it's not for me. But I would never want to take that away from anybody else. And I would never shade anybody else because they're really excited about their specific sports team, even though it's not for me. And so having that kind of perspective and sharing parts of yourself with the patients is the thing that it dramatically has helped my patients and myself. And then on a kind of like a systems level, really it's calling out things when you see them. For instance, if you see a colleague that, and this happens with techs, nurses, residents, attendings, um, my boss, sometimes they'll say things that are not necessarily meant to be mean or discriminatory, but they might make comments, and this is especially true for us non-passing trans people, and then people kind of in the middle, that jokes are casually made. And whenever I hear those, calling them out and saying, hey, like, I know that you didn't mean it this, any kind of like mean way, but here's like that might not be a good idea to say around your colleagues, or that might not be a good idea to say around the patients, because in the ER, everything's open. And so people can hear actually. And it would be devastating if I heard somebody making fun of the fact that I'm trans, stall over. That wouldn't make me feel good. Asking them their pronouns, you can do that in a very direct way. You can say, what are your pronouns? Or what I recommend doing is actually saying what your pronouns are without anything else. So introducing yourself. Hi, my name is Dr. Avila. I'm the supervising physician, and my pronouns are she, her. How can I help you today? And so that's opening up the conversation without almost like a requirement for the patient to have to respond. And I don't do that for everybody, by the way. I work in a kind of a reddish area of California. The big cities and coastal are generally speaking a lot more left leaning and blue, and much more, we'll say, experienced with visible queer people. But in central and eastern California, there are a lot of red counties. And whenever I have patients that come from those areas, I'm just a little bit, I might not say the whole pronoun thing because even that, would make them get all like uptight about it. And so being choosy about that is important. And lastly, there is actually a way. Epic is like by far the most common EMR, I feel like. There is a very easy way for, depending on your permissions that you have on Epic, to actually change the patient's pronouns on their chart or have registration change the pronouns on the chart. And you can even change the name. You can even say, like, it won't change anything from a legal perspective, but to have it on there as instead of, I don't know, Bill is the name of this person that was given at birth, and they go by Samantha now. That can be changed, and that can be changed through registration or through yourself, oftentimes, with the caveat that if the patient's legal name is one thing and their name, their actual name, is another thing. I try to avoid saying preferred name, just because Jalen is not it is my legal name now, but it's not a preferred name. It is my name. And I try to be very deliberate about how I say that. I don't say, what are your preferred pronouns? I just ask, what are your pronouns? Because it's, I think, more validating that way. Um, on insurance documents, it does have to match their legal gender and their legal name, but there are ways on the chart that you can actually put that so others know about it.
I'm going to stay with you, Jalen, and just take it a little bit further back because a lot of times when we look at the spectrum of, our healthcare continuum, the emergency start department is kind of the last stop. It's like when you're having an actual crisis, right? But
Mm,
what we know, especially for LGBTQ plus community, is there's a real clinical cost on patients delaying care and then ending up there. So I'd love for you to speak just what is the real clinical cost and what can we do to avoid that and support people to encourage them and this is I think it's agnostic of anybody. People just like are cost prohibitive and lots of
mhm.
different challenges, but I think this is an additional barrier for this community and would love for you to speak on that. And then Jess, if you have anything to add, please do.
Yeah. So when you look at the data, there's small studies of like 100,000 of us that kind of talk about our experiences. There was one that was published, I believe it was, I want to say 2015, another one that was 2022, and this is led by the Trevor Project, which Jess, you mentioned earlier. And a large percentage of us, I forget the exact number, but I want to say it's like 50% will avoid going to medical, like any kind of a medical institution, avoid seeking care, even if they think that their problem might potentially be life-threatening because of how poorly they are treated. That is, there's a thing, it's trans broken arm syndrome, which is somebody comes in with a broken arm and the focus is on the gender identity and the sexual health. And I lecture on this. And if somebody comes into the department and they have, let's say, a sprained ankle, knowing if they've had bottom surgery is not actually relevant at all. And so making sure to not ask irrelevant questions in general, honestly, but especially with trans people, is important. It helps them understand that we're there to treat them. We're there to help them. We're not there to judge them. And then almost invariably when I interact with a queer person in the department, when I'm discharging them or admitting them, I actually have a sit down and I say, like, listen, I'm so happy that you came in, and I'm really happy that we were able to get this work up and we were able to say as much as we can with the available technology today that you are not having a heart attack. And I really want to make sure that you know that in every industry, there are nice people and there are mean people. But the main thing is that you, the patient, you are healthy. And I want you to know that we try and we're working on this. And hopefully I have been affirming. Hopefully we've had a good experience. And I want you to know that please come back. If you have any issues, please come back and remember that it's about your health. And I mean, that's what we can do on an individual basis. And then on an institutional basis, there are a lot of other things that can be done. One of them being education, teaching other providers about queer people. For instance, teaching them that, you know, asking irrelevant questions about surgeries, about medicines they might be on, are um, they're triggering for patients sometimes because they already come to the emergency department scared that they're going to be treated poorly. They're going to, you know, I don't know if Megan, you're familiar with the story of Tyra Hunter. Has this ring a bell at all? So it was a story. I actually talk about it because it's so sad. It was a person who transitioned early, so in their adolescence. So they actually passed because they never went through a testosterone fueled puberty. And it was found out in the field, was in a car wreck. The paramedics found out in the field that she hadn't had bottom surgery, and they essentially refused to treat her. They had to call a supervisor. The supervisor loaded them up and took them to the hospital. And even though most of the records were actually lost, and this was, I read the whole court transcript, which was very difficult for me to read, by the way. I read the whole transcript, and they apparently drew labs, but they lost them. They had a chest X-ray that showed a tension hemothorax, and the patient's kind of presentation was just a horrible spinal cord injury. Couldn't walk, and she was essentially left out in the hallway and ignored. And she arrived hypotensive tachycardic, and they gave her a drip of fluids. And then when she became agitated, they gave her Narcan, which I always teach my residents, if someone is tachycardic, agitated, and hypotensive, it's not opiates. I promise you it's not opiates. And then because she was progressively agitated, the court documents actually state that they gave rocuronium. Actually, I think it was vecuronium, the longer acting paralytic, without anything else. And she died. And she truly, I mean, she died because she was trans. That is why. And so when we hear those stories and then we have crushing chest pain and we come into the emergency department, we're scared that we're going to be ignored and die. And having that conversation and listening to patients is the thing that kind of can combat that fear.
Thank you. Um, I hate to transition from such a critical story and moment. But as we look at, both of you have education in your background and in your worlds, and both from the personal backstory, Jalen, you have a military family, and Dr. Bunin, thank you for your service. I'm curious, that's an environment that creates certain other barriers, and just you already kind of alluded to this, and you most recently were leading DEI. So, not to be political about what is right or wrong about how we're looking at inclusivity in this time, because we know that it's under different discretion right now, right? But how are we looking at it from the education perspective as well as the military experience, and both of those parallel communities, and also the intersection of them? I'll hand it over to you to Jess.
Yeah, I believe that our students do come in as medical blank slates. And what we do, they're going to learn to do. And it matters. Every single interaction that they see matters. Every single thing they're taught in a classroom matters. Everything that they're taught is okay or not okay matters. And I think that all contributes to exactly what Jalen was saying. Um, as an example of a military issue that doesn't exist elsewhere, I told a provider that I was gay, but then I requested birth control so that I didn't get my period while I was deployed to a combat zone. And they couldn't possibly understand why a gay woman would want birth control. And I think it was, probably 20 or 30 years into my adult life before I had an appropriate sexual history taken. And so I think that I don't know if that's worse in the civilian world or military world because my life has been largely in the military world, but learning to take a good, safe sexual history when it's appropriate is really necessary and important. And having those doors open when it's necessary, not with broken arm syndrome. So things along those lines, I think, are really important to point out. I Some other things like with trans folks in the military, I spent all of last year really reading word for word every executive order that came out, every new threatened law that came out, every law that was passed somewhere, so that I would be able to support those who are in my population and give them good advice about it's time to just walk away or it's time to file a lawsuit and try to fight this. And people feel very differently about that. And I don't know if folks are hurt, but just last week, the trans ban in the military was found, unconstitutional. And so that may actually have to go backwards. But there are some folks who just didn't want to spend years of their life fighting that battle and didn't want to spend potentially the rest of their life hiding themselves. The military has been very strict about using people's pronouns assigned at birth, which has been hugely harmful and problematic. So things like that, like asking each individual what matters to them and having all of the knowledge yourself. Clearly, I understand that everyone can't read every law front to back and everyone can't read every executive order front to back, but having an idea of what's going on in public, in the federal government, in your state government, can be really helpful to individuals to help them make good decisions. And I think that that was a big part. There were folks that I said, if it's not going to harm you, then maybe you want to stay in because it can be a wonderful life. And in 3 years, it might be a wonderful life in the military. And there's others who, after having, back and forth conversations, I did recommend that they walk away based on their needs and their willingness to fight that battle at any given time. So I do think that there are things that are different in the military, but I think that there are things that should be the same. And that goes along with the respect for everyone, the learning a good sexual history, all of those, learning how to take a good sexual history, all of those are super important. And so I think that's what I would emphasize as part of that. Um, I think a lot of the things from a military side that I saw, I don't know if they're that different in the civilian world. So, for example, we had one of our EEO reps, we had one person who was in charge, our officer who was in charge, who believed that LGBTQ people were mentally ill. And I overheard conversations where this was the fact and took that to leadership who left her in that position to continue to do harm to LGBTQ people. So there's issues like that that can happen in the civilian world, same as the military world. Another one that happened that I don't know if it would happen in the civilian world or not. We, as a result of not being able to have a DEI office, not being able to have a community office, we needed folks who could support our LGBTQ population. And they were hard to come by and hard to know who those people were. And so we tried to create systems behind, and the initial recommendation was for all of the ombud services and all of the support services to come through the chaplain's office. But folks don't realize that a lot of folks are ostracized from their church for being LGBTQ and will never walk into a chaplain's office to get support for anything. And a lot of those voices just weren't heard as we were saying those sorts of things. So again, I think that there's a lot of tie over into the civilian population now based on laws of different states.
I'm curious for both of you, as we look at, system level change versus individual, a lot of what you've shared is like there's tremendous power in the one-to-one interaction, whether it's with a colleague or a student, or if it's with a patient. What are the system ideas that you have? Like in this ideal world, if we are leading institutions and trying to create culture change, what are some of your recommendations, or what things have you tried to influence or help embed so that we can kind of have more of a trickle down effect? I would welcome both of you to share.
Yeah, I'll start with that and then I'll pass it over to Jalen. But there were a lot of things that were, I think, directly harmful. And things like having core values on the wall or having mission and vision statements that are aligned with respect and support of others. But then when it came down to it, not enforcing those policies. So I think creating policies where it's very clear when someone is disrespectful or harmful that there's going to be consequences for that. And I'm actually someone who is a true believer in restorative justice. So it's sort of interesting for me to be a person that says, like, we need policies with teeth. But if we have folks who are deliberately being harmful and hateful, then we do need to have policies with teeth for those folks. I will also say that it is really harmful when an institution all of a sudden for June decides that LGBTQ health or LGBTQ anything is important, but don't talk about it any other time and don't support those folks any other time. So consistently having protections and support for folks all of the time is really important. And looking for barriers to those things instead of waiting for the complaints to come in and the harm to come in. So I think institutionally speaking, living by your values, having policies as an institution that support those values and having a lot of consistency there, being proactive about removing barriers for folks instead of waiting for complaints to come, and ensuring that there are protections and supports in place all the time, not just in June.
I agree with all of that. And one of the things that I've noticed is sometimes providers don't know what is appropriate and what isn't appropriate. And it's not really my nature, but it's something that I actively work on. And that is assuming that most people are actually benevolent and a minority of people are actually malevolent. And so when things happen, I usually try to approach it from a kind of like a oh, they just don't know kind of an angle rather than they're being mean on purpose and they need to be punished for that. For instance, recently I gave a lecture to a group of emergency medicine residents. I was invited to speak there, and I usually start off by just explaining words. What does queer mean? What is going on with the as some people call it, not me, but the kind of alphabet soup of queer people and why that is important to many of us, and explaining the difference between what is the difference between a bisexual person and a pansexual person and what surgeries are available. And sometimes just giving that education to people, just explaining to them what the differences are and why specific things are important. Sometimes it was coming, the way that they were kind of interacting and the things they were saying, it wasn't coming necessarily from a mean place. It was coming from a place of ignorance. And so educating them is helpful. It's the thing that addresses that. And that's actually been like pretty encouraging for me when I speak with people that don't really know, because sometimes when people are uncomfortable, they say silly things and they don't really mean it a certain way, but they've also never been called out for saying those things. So it's comes from a place of ignorance. And I hate to want to add on to all of the training modules that we have to do on a yearly basis, but something like that might be all somebody needs in their own time, in the comfort of their home, on their laptop. Someone virtually can explain to them what queer means and what surgeries are available, so on and so forth.
Thank you. I know we have a smaller community of folks on the call today, but I just want to open it up. If there's any questions, to drop it in the chat, or I'm welcome to you to come off mute and drop it in. Otherwise, we'll continue closing out the conversation.
I
Go
just
ahead.
want to thank you both. My heart is both breaking for all the things you shared, so much of which I didn't even know, just having to check into a hotel separately from your wife. Ah, and my heart is joyful in that you're both showing up as your authentic selves and sharing everything with us so that we can be better humans. And my 1% better today, Jalen, is I just ordered some colorful watch bands. So,
Yay.
yeah, thank you
I
both.
just want to emphasize how important that is. The reason that Jalen and I met each other, the very first thing she ever said to me was, I love your socks, because I was wearing socks with rainbows on them. Like it's so,
We notice
yeah,
those things.
every single time we notice. So thank you, Robin. I really appreciate you doing that.
Thanks. Any other, and I can just keep an eye on the chat, but I'll begin to kind of make the rounds to close this out. Um, we did talk about those signaling, whether it's if you are identifying as or if you're an ally. I feel like that having that physical presence, other modes of offering that support that you feel like we can offer to our group today.
I think most of it is going to be emphasizing or slightly altering the things that we've already said, which is I talked about how I was willing to mention my wife in talks. And so for leaders, I think it's really important for leaders to go first and show some sign of good faith, whether that's something about their own vulnerability, whether it's telling a story about how they responded to feedback they got when they misgendered someone. We love nothing more than not having to correct someone because a straight ally does it for us. So there's a lot of little things like that along the same spectrum of calling people into conversation, but having other leaders do that so that the queer folks don't have to do all the work. The other thing I would say is along the education front, the bulk of my LGBTQ education, other than from my life, was actually from television and movies. And like,
Hmm.
I encourage people to watch shows with trans characters, to watch shows with gay characters, and normalize that experience for yourself, and also start to develop more empathy for what it's like to live in this world. And so I think that that's a huge pl thing that people can do that's not taking more online training at work, but is making an effort to improve themselves so that they can be a better provider for all of their patients. And again, admitting when you've made mistakes, admitting when people have corrected you, sharing that story so that you are showing vulnerability first as a leader. I think those are really key things. Another thing I want to mention is a lot of time on climate surveys. If we score in the 95th percentile of something or the 94th percentile on something, we think that's great. But what if that 5% or 6% is your whole LGBTQ population? So I think focus groups instead of climate surveys are really important to make sure that when you have a population that is 4 to 6%, whether that's based on race or whether that's based on LGBTQ, make sure it's not those folks that all have the same problem with something that's happening when other folks can't, again, no harm intended, but they can't be aware of the fact that that's a problem or that that's harmful. Just like Robin says, you never thought about the fact that you wouldn't be able to check into a hotel room. If it's not your life, you would never think about it. So super important to learn what those things are and not just trust that 95% on a climate survey is a great answer when 5% who are all similar are being harmed.
And follow queer providers or queer content creators, I'll say, on Instagram or whatever social media you use. I've actually learned a lot about things that don't directly affect me from social media. I mean, we kind of focus on social media being this almost like a necessary evil, but it also can be a very good thing because we can see kind of how other people interpret their environment and how they live outside of what we typically experience.
Great advice. And as we close out with, this conversation being under the umbrella of women in medicine and our community of such a diverse population of people showing up in different ways, what's one thing that's giving each of you hope?
Do you want to go first, Jess?
Okay, I'll go first. I will just say that I'm relatively new to women in medicine. My first Women in Medicine Summit was last year. And when I got there, I didn't know what to expect. I'm not a lover of conferences because I'm an introvert and I find that very stressful. But minute one, I felt very included in Women in Medicine. I felt like people were there to get to know each other and support each other. And that gives me hope to know that there are communities that genuinely do want to support each other, that there are conferences where you're going to love every minute of it instead of being emotionally drained by the whole thing. So that's giving me a lot of hope for the future.
Yeah, I second that Women in Medicine conference experience. I'm always leery. I'm nervous, a little scared whenever I go into a space that doesn't have as much trans representation. And when I've been seen and accepted as a woman, which again, that is my most important identity from the beginning of the Women in Medicine conference. So, and it wasn't that even though my lecture was specifically on being trans, I didn't feel like that was what people wanted to get to know. It was almost like they just wanted to get to know me as a person and hang out with me. And the gala was like my favorite part. I know I'm supposed to love education. I do love education, but getting to dress up and being around other people that are dressed up is probably my favorite thing. Um, and just being part of the group because I am me was kind of huge. The other thing that gives me hope, honestly, is seeing young people that are open and out and advocating and even fighting. Young people that are openly themselves is something that I didn't have when I was a kid. I didn't, the two careers that I knew that trans people could get into growing up, and this is based off of my consumption of media, was homeless or sex worker. Those were the representations of trans people before. And to see uh, I'm blanking on her first name, but her last name's Clayton. She was a trans woman who was on a show called Sense8, which was made by the people who created The Matrix, which coincidentally they were the Wachowski brothers before The Matrix, and then afterwards they're the Wachowski sisters. They both transitioned after The Matrix came out. And then seeing, even though you might not agree with everything in the show, the content of the show, Hunter Schafer in Euphoria is another great example, is seeing that front and center. And for her character in Euphoria, her being trans is not her main storyline. It is a part of her, but her main storyline is about being a single kid, a kid with a single parent, I mean, and dealing with the pressures of trying to be popular and being yourself and all that. And seeing that, that's what gives me the most hope. I feel like we have a bit of a dip right now in queer and trans rights, really equality. But I think overall, if we think about how things are now compared to how they were when I was a kid, I think overall things are improving. And hearing stories and seeing people that are out there and open, vulnerable, is so encouraging and gives me so much joy.
Thank you for that. I think that both of you beautifully shared both yourselves today, and we're grateful and proud of both of you for being part of our community and for representing who you are. And we are grateful to celebrate all that are celebrating Pride this month. It's not just this month, this is just an opportunity for us as women in medicine to uplift and celebrate those that are part of our community, but we hope to continue these conversations year round. So thank you.
Thank you.
As we close out, I just want to share, you can definitely go to our website to check out our upcoming events, including not promo, not paid, the Women in Medicine Summit. Along with the summit, I just want to say we have a few days left to nominations for our awards at that weekend, as well as there's still opportunities for our students to apply and volunteer. So please check out those opportunities on our website, as well as, part of today's programming and what we're trying to do is build out a movement throughout the year with our WIMbassadors. So you can check out what it looks like to join as a WIMbassador thought leader or just a WIMbassador on our website. But I just want to again thank Dr. Jalen Avila and Dr. Jess Bunin for your expertise, for your advocacy, and all that you do for women in medicine's community. So thank you all for being here today.
Thank you.
Thanks for having us.
Thanks.